Okay, so moving on to twinning. Do you remember which of the five types of errors in organ morphogenesis twins are at risk for? That would be deformation, since it can be crowded in the uterus and the twins can put physical pressure on each other. So, the two types of twins are monozygotic, meaning they came from one embryo, one egg, so one egg and one sperm, and are genetically identical, and also you have dizygotic twins, meaning that they came from two separate embryos, like you can see here. In other words, two eggs fertilized by two separate sperm. They were fertilized independently and are therefore genetically different. Now, dizygotic twins will each implant separately have their own chorion and placenta and their own amniotic sac. Monozygotic twins, however, can share some of these things depending on when the embryo divided in two. In about 25% of cases, the embryo of monozygotic twins splits before the chorion is formed at day 3. And these embryos will have their own placentas, chorions, and amniotic sacs, just like dizygotic twins. So they're called dichorionic, diamnionic. Now, 75% of twins, so the most common one, the embryo will split between days 3 and 8, which is when the chorion has already formed, but the amniotic sac has not. So these twins will share a chorion and placenta, but they will each have their own amniotic sac. They are called monochorionic diamniotic. Lastly, we have less than 1% of twins, so very rarely, which are monozygotic twins, but they split after the amnion forms, so they are monochorionic monoamnionic. These twins are at risk for what? Being conjoined, exactly, especially if the split occurs after the bilaminar disc forms at day 12. In terms of the step 1 exam, remember that number of chorions equals number of placentas. In the most common form of twinning, how many chorions and amnions are there? So these would be monochorionic diamniotic, so there would be one chorion, two amnions. A good way to remember this is mom's chorion, twins amnion. M in mom for monochorionic, and twin meaning two amnions. Hope that helps. So the placenta. We've mentioned it a few times now, but what exactly is it and what does it do? The main function of the placenta is nutrient and gas exchange between the mother and the fetus. So you can see here in the image, so the uterine vessels and uterine glands, so this would be the mom's side, whereas these with the syncytial trophoblast, cytotrophoblast, this would be baby's side. So the fetus contributes the chorion to the placenta, and this includes the cytotrophoblast, syncytiotrophoblast, which are the outer layers of the chorionic villi. The cytotrophoblast, which are entities that look like the cells in the image, as you can see over here, are kind of like the stem cell of the placenta. They can differentiate into syncytiotrophoblast or form more cytotrophoblasts as the placenta grows. Now, syncytiotrophoblasts are the white layer outside of the cytotrophoblast shown here. And so these cells actively invade the uterine wall and secrete HCG, so you can see how they're going right into the uterus. HCG is necessary during the first trimester to maintain the corpus luteum, which secretes progesterone. After the first trimester, the placenta basically takes over progesterone production and the corpus luteum degrades into the corpus albicans. Now, the maternal contribution to the placenta is called the decidua basalis, and that's essentially right here. And do you guys know where it is derived from? That's right, the endometrium. So maternal arteries and veins flow through it to supply blood to the placenta. Maternal blood pools in these large spaces called lacunae, so all these lacunae over here, around the chorionic villi, and gases and nutrients can diffuse through between the mother and the fetus. For blood to get from the placenta to the fetus, it travels through the umbilical cord. As is the case in the pulmonary circulation, the umbilical arteries have deoxygenated blood, and the vein has oxygenated blood. Now remember, the artery and vein naming convention is in reference to the fetal heart, not the mother's heart. So there's only one vein, which supplies blood to the fetus by draining into the IVC, the inferior vena cava, and there are two arteries which return deoxygenated blood from the internal iliac arteries. These vessels are supported by Wharton jelly, which is a gelatinous substance that contains many stem cells and is also made up of fibroblasts, macrophages, and mucopolysaccharides such as hyaluronic acid and chondroitin sulfate. So how's the umbilical cord form? So it starts as an endodermal evagination from the developing hindgut called the allantois. This extends into the urogenital sinus during week 3. A mesodermal connecting stalk surrounds the allantois, and this is the early umbilical cord. Now the fetal bladder is connected to the yolk sac through the allantois, which will become the urachus. Blood vessels from within the stalk connect the fetus to the placenta, and the allantois eventually regresses, leaving just the arteries, vein, and urachus in the umbilical cord. To help you understand this, just remember that if the urachus fails to obliterate, then there will be urine discharge from the umbilicus. All the U's should help. Of note, if the urachus only partially closes, it can form what's called a urachal cyst, or sometimes it can cause a vesico-urachal diverticulum, which would be an outpouching of the bladder. Another important structure for carrying nutrients to the embryo is the vitelline duct, and this connects the yolk sac directly to the lumen of the midgut. This is normally obliterated during week 7, since the embryo is no longer receiving nutrients from the yolk sac, but sometimes abnormalities occur. You know what will happen if the duct does not close? Then you get what's called a vitelline fistula. That's not too good because now the baby will be pooping out of the wrong end. As you've seen in the GI chapter, partial closure causes meccal diverticulum, which is an outpouching from the ileum that occurs in about 2% of the population and is generally asymptomatic. But it can cause symptoms such as rectal bleeding, pain, intestinal obstruction, volvulus, and even intussusception. The diverticulum may contain heterotopic gastric mucosa and or pancreatic tissue contributing to these symptoms. Now after birth, the urachus regresses as well, leaving a fibrous remnant known as the median umbilical ligament. USMLE is obsessed with you knowing that the umbilical arteries regressed into the medial L umbilical ligament, and that the allantois/urachus will turn into the median umbilical ligament. Next, let's discuss the origins of structures from their embryonic forms. These next slides are important as they contain material that is tested frequently in step 1. So, different parts of the aortic arch and nearby vascular structures arise from different branchial arches. During the 5th week of development, the paired arteries and aortic sac that comprise the primitive circulation system begin to fuse, sprout, and regress to form the adult vascular system. So the first arch develops into part of the maxillary artery. This is an interesting one because the USMLE loves to ask about epidural hematomas in the first arch. Now an epidural hematoma is due to what? So when you have a laceration of the middle meningeal artery secondary to cranial trauma. Well, what artery does the middle meningeal artery branch off of? It's the maxillary. You see the point? The second arch develops into the stapedial and the hyoid arteries. In terms of the USMLE, you need to be aware that the stapedial artery supplies the stapedius muscle. What does the stapedius muscle do? It controls the stapes in the ear, which dampens loud sounds. Normally after birth, this embryonic structure should regress. If not, then adults can suffer of persistent stapedial artery in which they get headaches where they can hear their heartbeat, and they can also get hyperacusis, so very high sensitivity to sound. The third arch forms the common carotid artery and the proximal part of the internal carotid artery. The fourth arch develops into different structures depending on the side of the body. On the left, it forms the aortic arch. On the right, it forms the proximal part of the right subclavian artery. The fifth arch regresses and is absent in the adults. So no 5. Be careful with this one as the USMLE likes to put it as a distractor in the answer choices. So now we have the sixth arch, which forms the proximal part of the pulmonary arteries, and on the left, it forms the ductus arteriosus as well. So here's a flash quiz. The right recurrent laryngeal nerve loops around a structure derived from which aortic arch? It would be the fourth arch. The left recurrent laryngeal nerve loops under the arch of the aorta, so it would be the fourth arch as well, although it does go immediately adjacent to the ligamentum arteriosum. Another little tidbit. A newborn has a continuous machine-like murmur. Which aortic arch bears relevance here? If you remember from cardio, this would mean the newborn has a patent ductus arteriosus, which is derived from the sixth arch. Another important structure is the branchial apparatus, also known as the pharyngeal apparatus, which is made up of branchial clefts, arches, and pouches. Now, the lower head and neck development begins with the appearance of the pharyngeal apparatus. The clefts are an external lining derived from ectoderm. Arches are mesenchyme derived from the mesoderm and neurocrest cells. The pouches are an internal lining derived from endoderm. So remember, CAP covers from outside to inside. C for cleft with ectoderm, A for arches with mesoderm, P for pouches with endoderm. So let's go into more detail about this. The branchial clefts. So the first branchial cleft develops into the external auditory meatus. You can see it right here. The second, third, and fourth clefts formed these temporary cervical sinuses, which are obliterated by the proliferation of the second arch mesenchyme. One type of malformation, called a persistent cervical sinus, refers to a branchial cleft cyst within the lateral neck. The way USMLE likes to test on this one is to present a kid with a painless lump on the side of his neck that does not move when he swallows. So the branchial arches. So the table in the book is very high yield for the exam. This is another one you're going to have to know. Let me try to walk you through it, all right? First of all, remember that the muscles and arteries are derived from mesoderm, while bones and cartilage are derived from neurocrest cells. Also, that each arch comes with its set of nerves. So, if we start off, the first arch, I like to use the word M for it, because there's a lot of M structures associated with it. You have the Meckel's cartilage, the muscles of mastication, and the maxillary and mandibulary nerves. So that's helpful. Also, for the second arch, it's more of an S kind of sound. So you have structures such as the stapedius, and these will be associated with the facial nerve, cranial nerve 7. The third arch goes with the stylopharyngeus and cranial nerve 9. A pretty simple one. Now, arches 4 through 6 cover basically the rest of the neck with the pharyngeal constrictors, the larynx, and all of these are innervated by different branches of cranial nerve 10. Now, I've included the major structures here in this table, but make sure you know the whole thing from the book. Moving on to the branchial pouches. What is the germ layer of the branchial pouches again? That's right, endoderm. So the first pouch contributes to structures of the ear, which are the middle ear cavity, the eustachian tube, and the mastoid air cells. The second pouch develops into the epithelial lining of the palatine tonsils. So 2 tonsils, if that helps. The third pouch contributes to 3 structures: the thymus, the left and right inferior parathyroids. The dorsal wings develops into the anterior parathyroids, and the ventral wings develop into the thymus. Okay? The fourth pouch develops into the superior parathyroids, and it is important to note that the fourth pouch actually ends up above the third pouch, because the fourth pouch is giving the superior parathyroids, and the third one is giving the inferior ones. So, multiple endocrine neoplasia, also known as MEN2A, is a syndrome characterized by a constellation of tumors. It's caused by a gain-of-function mutation in the germline RET proto-oncogene, which affects neurocrest cells of the adrenal medulla, leading to pheochromocytoma. The third and fourth pharyngeal pouch, leading to parathyroid tumors, and the fourth and fifth pharyngeal pouches, leading to parafollicular cell tumors, aka medullary thyroid cancer. There's a quick review of endocrine for you. So, question time. An infant is born with facial abnormalities, including a small jaw and low-set ears, and is found to have an absent thymic shadow on a subsequent chest x-ray. Labs are significant for hypocalcemia. He most likely has what syndrome? You got it, that's DeGeorge syndrome. So this occurs when pharyngeal pouches 3 and 4 fail to develop into the thymus and parathyroid glands. So these infants typically have a C-cell deficiency, since they have a thymus aplasia, hypocalcemia due to the parathyroid failure, and facial abnormalities and cardiovascular abnormalities. For bonus points, what would be the genetic mutation associated with this? That's right, it's a 22q11 deletion. So that'll be on chromosome 22, the Q arm, band 11.